Well, hello, it's Bruce Williams again, and today I'm pleased to present my 8th and final installment in this series on the selected gross pathology of the nervous system, in which we're going to talk about neoplasms. You'll probably notice that this lecture skewed a lot more heavily toward the dog and cat, two species who are allowed to live out their normal lifespan. So we get an increased frequency of brain tumors, even though they're still rare in these species, as opposed to our production animals. As I do at the beginning of all of my lectures, I want to thank my friends and colleagues who provided me such great images over the years, which allow me to put these lectures together. And we're going to start with the brain of a dog, and you'll see a very large mass compressing one of the cerebral hemispheres. About 80 to 90% of what we see in the dog and cat, respectively, within the skull, in terms of neoplasia, are going to be meningiomas. These are tumors which arise from meninges, primarily arising from the arachnoid layer. They tend always to grow out to start with, but the brain is enclosed in a bony case, and there's only a limited room to grow outwards. But they're going to continue to grow regardless when they hit that boundary. So what happens generally is they will begin to compress the underlying brain tissue, and you'll get pressure atrophy. I'm going to show you that in just a moment, but I hope that you've been paying attention to all the lectures. In the first lecture on nonspecific lesions, we talked about consequences of increased pressure within the skull, cerebral edema, and positional shifts of the brain. And I hope if you were paying attention, you spotted this area in which the parahippocampal gyrus has protruded back under the ridge of bone known as the tentorium cerebelli into the posterior cranial fossa, where the cerebellum normally sits. It looks like there has been pressure backwards on the cerebellum as well, and we may have a small area of cerebellar coning. So now we're starting to put a lot of the concepts from all of these lectures together. Here's a formless fixed specimen from a cat, which really helps to illustrate the point that these tumors only have a limited space to grow outwards, but they're going to continue to grow. They're going to grow back inwards. Note that there's no infiltration at all here, and that's the case with almost every meningioma in cats. Most meningiomas in dogs don't infiltrate. They grow as an expansile mass, and they cause pressure, necrosis, and atrophy of the underlying tissue. Hopefully you also notice the nonspecific finding of hydrocephalus with greatly dilated and displaced lateral ventricles in this case. The size of this mass has caused a positional shift away from the mass, although I don't see that the cingulate gyri have been pushed underneath the falx cerebri. As we said before, they don't tend to infiltrate. In dogs and cats, probably only about 2.5 of the intracranial meningiomas are malignant and will infiltrate. They tend to be benign tumors, which makes them, if they're caught early, before you have significant atrophy of the underlying brain, a good surgical option in people and in pets nowadays. Those that arise outside the cranium, because you have meninges around the spinal cord, even around spinal nerves, you can see them in the vicinity of the optic nerve, one of the variants. 9 variants of meningiomas. One of them is the retrobulbar meningioma, which encases the optic nerve. But they tend to be a little bit more malignant outside of the skull than the ones that we see within the skull. As I said before, there are 9 different types, but most of them act in a fairly similar fashion. So I don't get too involved, but if you're really into neuropathology, you probably should become familiar with some of the various types, including the meningoendothelial mitosis and the cymomatous. but to me they all sort of act the same way. We've already looked at the most common location, which is up here in the supratentorial meninges. Another common spot, which is illustrated in this great picture from a ferret from Dr. Mike Garner, who gave me this maybe 30 years ago, is in the telochoroidea of the third or the fourth ventricles. And the telochoroidea is a little layer of the pia mater, which spans the top of the ventricle, which is where the choroid plexus originates from. And so you will see them more commonly in cats, way down here, pushing the two cerebral hemispheres apart and compressing the midbrain. You can see meningiomas in absolutely any species. Here is a picture from an article many years ago in Journal of Comparative Pathology with a very distinct meningioma compressing the cerebral hemispheres of a baboon. So, meningiomas, generally benign, extremely common. One other, which acts as a mass lesion, and it's a very rare finding in the dog, is a condition which is known as meningoangiomatosis. We get that from the humans. It's been diagnosed in a couple species, most commonly in humans and dogs, but it's still a very uncommon lesion. And this is a leptomeningeal plaque composed of meningothelial cells. It also rises in the subarachnoid space, and it extends along perivascular spaces, often compressing the underlying parenchyma. So it's not quite a neoplasm, it's not a meningioma, but the tremendous proliferation of the cells within the meninges and the accompanying blood vessels will act as a space-occupying mass and will cause neurologic lesions. The pathogenesis is truly unknown in these. Some groups think that it's a malformation. Some believe that it's a hamartoma, but it's very uncommon, and chances are you'll probably never see one. Okay, let's move into the tumors of the brain proper. For those of you who are trying to keep up or have tried to keep up in the past years with the evolving nomenclature, I want to direct your attention to, I think, a must-have article. If you look at any type of brain tumors at all, this one was written by Dr. Jay Kohler and Andrew Miller and a host of other outstanding veterinary and human neuropathologists in hopes to sort of consolidate the nomenclature of glial tumors in the dog and to bring it closer to a continued and somewhat more advanced evolution in humans toward a more simplified system. When I was coming up as a resident, you had astrocytomas and you had oligodendrogliomas, and then you had a lot of really odd one or two off type of tumors like the gliogliomas and the gliomatosis cerebri. The humans basically started this by sort of consolidating most of the glial tumors. And if we talk about tumors in the dog brain, and we said 80 to 90% are going to be meningiomas, then 10 to 15% are going to be gliomas, tumors of glial origin, which generally are the oligodendrogliomas and the astrocytomas. The humans over the last number of years have been consolidating these into a classification which is essentially astrocytoma versus oligodendroglioma, and then criteria for a high grade and a low grade variant of each. It makes it much easier to understand and classify these tumors. And this paper was written in 2018. It's called a revised diagnostic classification of canine glioma by Kohler et al. In the Journal of Neuropathology and Experimental Neurology. I strongly recommend everybody get that, review it, and if you are diagnosing brain tumors, at least in the dog, it has some excellent advice in terms of interpretation of immunomarkers and the impact of how much time the tissue's been out of formalin, on how those markers work. It's a fantastic paper, and I can't say enough about that. Okay, so with that in mind, we're gonna look at the basic type of brain tumors, and the one that I want to start with, because it's the one that everyone can sort of understand a lot of concepts about, is the oligodendroglioma. This is a neoplasm that arises from oligodendrocytes, which are the ones that wrap around neurons. Each oligo probably serves as about 100 different neurons, and they wrap their cytoplasm around it, squeezing out all of the, just leaving the membrane with all the cytoplasm basically squeezed out many times. And this is known as myelination. Yes, the myelin around myelinated nerves is the cell membrane of the oligo, and it allows the nerve impulse to go much faster. But unfortunately, sometimes we see neoplasms of oligodendrogliomas. Brachycephalic dogs tend to be predisposed for this, and they tend to be predisposed for all types of glioma. This is a fantastic one, because it illustrates a couple of things about brain tumors in general and oligos. These are largely white matter neoplasms. Arising in the white matter, they may extend into the gray matter over time, but they arise in the white matter because, remember, the oligo is the nurse cell, so to speak, of nerves within the white matter. So this one is located very nicely. You can see it's coming out of the white matter. Another thing that you want to note about these particular neoplasms is they are generally very well demarcated from the surrounding tissue. They tend to grow slowly. Okay, slow-growing tumors tend to push stuff out of the way. They're very polite, and so they often have a very nice area of demarcation. You can see it's a well-demarcated tumor because you can see where the tumor stops and the rest of the tissue begins. Oligodendrogliomas have a sort of gelatinous appearance, because when you think about it, what they do is they form myelin, which has a tremendous amount of fat in it. So they tend to be very gelatinous, and they often have hemorrhage within them. We see a little bit of pink in here. So when I see something that looks like it's coming out of the white matter, it's growing slowly, it has an ooey gooey consistency and a little bit of hemorrhage, I'm going to go with the oligo. Now I'm going to need my microscope to tell me whether it meets the criteria for a low grade or a high grade. But based on the gross appearance, I could be fairly confident that this is an oligodendroglioma. I'm going to show you one more. Here's another one. Okay, arising in a different part of the brain, but once again, it has that ooey gooey consistency. Little bit of maybe hemorrhage here. It's fairly well demarcated. Even looks like it might be arising in the white matter. So oligodendrogliomas, I think they're a little easier to diagnose based on gross appearance. But obviously brain tumors are one of the reasons God made microscopes, so we never want to just look at a brain tumor and say, oh, that's an oligo, and be done with it. I'm going to show you one more. It's a great picture by Dr. Stephanie Schrader. And this is an unusual presentation, but I'm going to show you another unusual presentation of an oligo when we get down into the spinal cord. And this is one that has gone into the ventricles. This is a pretty rare occurrence with these tumors, but it also gives me a good chance to say, hey, did you notice the hydrocephalus? Here we have great distension of the third ventricle. The lateral ventricles are markedly distended because this tumor is obviously impeding normal CSF flow. So occasionally they will get into other parts of the brain that you don't expect, but they can pop up any place that you have white matter, periventricular white matter, wherever. Now, So half of the gliomas are going to be oligos and half, maybe not by number, but certainly you have two big categories, oligos and astrocytomas. Astrocytomas tend to be faster growing over time. They are classified into four different classifications or old classifications of the humans and dogs. We're getting away from them now, dropping them down to high grade and low grade. But the classic high grade astrocytoma or grade 4 is one that is rapidly growing. It grows so fast you often have large areas of necrosis within it, and it has gone by the name over the years of glioblastoma multiforme. It even sounds more serious than astrocytoma. Oh my gosh, I got a glioblastoma multiforme. That sounds terrible. So we have low grade and high grade. Now, once again, this is a tumor, at least in the dog. The brachiocephalics are predisposed. This is one that can pop up anywhere, but there are certain parts of the brain, like we talked about with the meninges, that are predisposed. And this is an absolutely fantastic location right here, which is the piriform lobe of the brain. Here's the unaffected one here. And if you see a tumor that is arising in the piriform lobe, I'm going to think about astrocytomas first and foremost. You can also see them in the temporal lobes. You can see them in the thalamus as well. I think that most of the ones I see, it simply might be just my particular luck, tend to be the more aggressive kind. But the slow-growing ones, it's very tough with the small ones to tell them from normal, because as opposed to the oligo, these tend to be much more infiltrative. They insinuate. Some of the old forms of what we called gliomatosis cerebri are being reclassified into astrocytomas, and those are ones that are so well dispersed throughout the neuropil that it just looks like a very hypercellular part of a neuropil until you realize, hey, there's a tumor in here. The rapidly growing ones often have hemorrhage and necrosis, and it makes them a little more easy to identify. Let's take a look at this particular tumor on cut section. And so we've cut this, and there's not a whole lot looking at it that, on really cursory inspection, you're going to pick up. Now, when we look a little closer, plus we I told you that there was going to be one of the piriform lobe. Let's look at that piriform lobe, okay? And what you see is a very infiltrative neoplasm. At one point, this has crossed the midline. Okay, we've distorted the lateral ventricle. This is all neoplasm here. There's not a lot of hemorrhage. There is a fair amount of edema, which sort of makes the white matter of the corona radiata very difficult to see. So this tumor probably goes all the way up in here. And this is a little bit more the nature of astrocytomas as opposed to oligos. Oligos can be very infiltrative, but usually the astrocytomas are the ones that cover ground a little more quickly. Here's another astrocytoma rising in the piriform lobe, and this one you can see that there are areas of hemorrhage, areas of necrosis. A lot of this hemorrhage may represent areas of necrosis as well. Okay, this is a tumor that, although the hemorrhage and necrosis causes it to be very well demarcated, is one that is growing very quickly. These tumors rapidly outgrow their blood supply. You know that if a neoplastic cell is more than 2 millimeters away from its blood supply, it's dead. That's why we see so much hemorrhage necrosis in large tumors of any type, not just brain, but any tumor that's rapidly growing and outgrows its own blood supply. You're going to have a large necrotic part of that tumor. Okay, so make sure to get that paper by Kohler. It's a great paper. It is freely available on PubMed, so there's no reason you don't have to pay to get it. And make sure that that is one that you can refer to on a regular basis. This is the way it's going, and I think it's a very good thing. Okay. This is another neoplasm, and if you looked at this and you said, I think that that is an astrocytoma, I don't really have much of a problem with that. Obviously, this thing is very invasive. There's a lot of hemorrhage and necrosis. This one arose from the lining of the ventricles, the ependymal lining, and these are known as ependymomas, or more properly malignant ependymomas. I don't know if I've ever seen one that was truly benign. These tend to be very infiltrative, and one of the problems is that there are really no good immunohistochemical markers for that. There are good markers for astrocytes. GFAP is a good one. There are good markers for other glial cells. Olig-1, we find, initially when it came out, we were like, oh great, it's for oligodendroglial cells. Unfortunately, Olig-1 is one of the immunos that's poorly named, and you can have positive astrocytes as well. It really marks glial cells, and both astrocytes and oligos are glial cells. So if you get a positive Olig-1, don't throw up your hands and say, I've got an oligo. You've got to make sure that the morphology is good, that it's negative for GFAP as well, because oligo is going to be positive for your astrocytes as well. With ependymomas, there are no good IHC markers. Even the paper by Kohler et al. Says, hey, ependymomas are going to be, or malignant ependymomas are going to be negative for these. They're not going to work with your glial markers. So one of the things is that they're not positive for your standard glial IHCs. These tend to be somewhat triangular, carrot-shaped tumors that have a lot of rosettes in them. I think that ependymomas can be a very difficult diagnosis. You have to take a lot into effect, including negative immunohistochemical results, which I always hate, and a good morphology. So way back in the day when I started, we would put PTAH on these, and because ependymal cells have a lot of cilia, the basal bodies would appear as little blue dots in the apical cytoplasm. That is a tough thing to see. I don't know if I've ever picked it up or confidently picked it up, but it's where we were then, and we haven't made that much inroads yet. Ependymomas, very infiltrative, aggressive tumors. They leave the ventricles and they just go diving straight into the parenchyma. One of my dogs died of a ependymoma, and we were lucky to have an additional 4 months with her. And one more case, obviously these tumors arise in and around the ventricles. Here's a nice periventricular location. These usually pop up. This one is a cat. These usually pop up in the dog and cat in the third or fourth ventricle, but they're always periventricular, although this one has totally obliterated any sign of the ventricle. Another tumor that shows up in the ventricle of dogs and cats are tumors that arise from the choroid plexus. These are epithelial tumors. And what I want you to see is these particular tumors, being epithelial, have sort of a granularity to them. They have a pattern, a rough pattern to them, and that's not uncommon. Sort of like what we see in the meningiomas, which sort of have a sort of a gritty texture to them, and we see this in the choroid plexus tumor. So that helps me at least bring this tumor into the differential diagnosis. The benign tumors are choroid plexus papillomas, being epithelial tumors, and their proliferation of the tumors of the cuboidal epithelium that lines the choroid plexus. They may obstruct CSF, and as we see once again, we have a dilated lateral ventricle down here. What appears to be probably the end of the third or the fourth ventricle is somewhat dilated. There's a little bit of a positional shift here, but this grittiness to this suggests that this is arising from the choroid plexus, and we can see that it is infiltrating underneath into the diencephalon or the midbrain, and this would qualify as a choroid plexus carcinoma. This is one of the few tumors that when it gets in the ventricles, they have a tendency to break off and they can metastasize to other parts of the ventricular system, or they can get caught up in the cerebrospinal fluid, come all the way out down by the cerebellum, and then rotate back, and they can seed the subarachnoid space. And here's one more, choroid plexus carcinoma, hydrocephalus, and you can see the infiltration down here into the periventricular white matter. Okay. There are also a class of neoplasms, they're occasionally seen, that are most often seen in young animals, in calves, in children. These are the primitive neuroectodermal tumors, also known as PNETs, and they basically arise from very immature bits of ectoderm. And one of the more common ones that is seen in calves used to go by the name medulloblastoma. Whenever you hear blastoma, it's usually a young animal, it's usually undifferentiated ectoderm that gives rise to a fairly aggressive neoplasm. You hear about hepatoblastomas in horses, retinoblastomas in children, and the medulloblastomas. Most people now call them primitive neuroectodermal tumors, or PNETs. The neuroectodermal tumor that is called the medulloblastoma very characteristically pops up in the area of the fourth ventricle between the back part of the cerebral hemispheres and the cerebellum. And this can do whatever it wants. That's the thing about these primitive ectodermal tumors. They often will differentiate along multiple lines. The hepatoblastoma can go hepatocyte or can go biliary, and this particular medulloblastoma can differentiate along ependymal, glial, or even neuronal cell lines. The animals generally will develop neurologic signs. It does interfere with the flow of CSF as well, and they're usually picked up fairly soon, and that's why it's a tumor of calves, because they just don't get any farther. So primitive neuroectodermal tumor, these tend to have, like the ependymoma, they tend to make a lot of rosettes, and whether it is a Flexner-Windner-Steiner rosette or a Homer Wright rosette or even a Homer Simpson rosette. I tend not to remember the names of those as much, but the presence of rosettes and pseudorosettes often leads me to a diagnosis of primitive neuroectodermal tumors. You can see them in the front of the brain as well. Those are known as esthesioneuroblastoma. Often arising from the olfactory lobes. So those are the main primary neoplasms of the brain. In many species, like ferrets, but I would say like there are many other species, the most common neoplasms of the brain are metastatic tumors. I know in ferrets, working with them for many years, lymphoma was the number one tumor of the brain. They didn't get that many primary tumors, lots of metastatic tumors, and the brain is a place where you can see extensive metastasis of various types of tumors over time. This is a brain from a dog, a wonderful picture from Dr. Paul Stromberg. Got a couple things going on here. One is a metastatic hemangiosarcoma. Just things I want to mention on this particular one. You'll notice that this, and in a number of other slides in the lectures that I showed you, the center of the area generally is sort of whitish. You can see that the blood is redder, and the problem is that this brain probably has not been fixed long enough. I've learned over the years, don't rush brains. Some people say that small brains are fixed in 2 days. I usually give my brains at least a week. I don't think there's anything that now there's some people that are going to want to get the results back fast, but generally I try to leave my brains in formalin by themselves, and preferably suspended so they don't get smushed along with everything else. So I try to leave it in a week, and that's just my thing. Some people can say I can do it a lot faster, but I like to get the job done right. And so this is one in which somebody pushed this probably through a little quicker than necessary. Now the other thing is, could this be another type of neoplasm? Well, there are a lot of questions here. Number one, is it primary or metastatic? Well, the way this is distributed all throughout, you have variably sized areas. I would say it's metastatic, but you can certainly have primary hemangiosarcomas in any organ because there are blood vessels in any organ. The other thing is, some areas just look like a lot of hemorrhage. This area that's well fixed looks a little darker. Could this be a melanoma? Certainly could. So this is a nice disseminated one and this is not uncommon with hemangiosarcomas, that over time you get a lot of little bits break off, whether it's in the right atrium or wherever it's at. And these little bits of neoplastic endothelium tend to take root just about anywhere because any organ sort of recognizes endothelium as a normal component. So hemangiosarcomas tend to metastasize very widely. Here's a great picture from the University of Tennessee, Don McGavin, and this is a large metastatic focus from a mammary carcinoma. So the brain can be the recipient of metastatic neoplasia as well. Not every tumor. If you didn't tell me anything about this, that the dog had a large mammary carcinoma, hey, one of my first thoughts is going to be oligo. It looks like it grew slowly. There's hemorrhage. It's well demarcated. So history is always very important, especially when we're doing gross pathology. Okay, let's leave the brain and move into the spinal cords and the peripheral nerves, and there are fewer neoplasms down there, so we should be wrapping this lecture up in fairly good order. This is an absolutely wonderful neoplasm from the dog, and we have a large infiltrative intradural neoplasm. When we get in the spinal cord, we often talk about intradural versus extradural tumors. One of the most common extradural tumors is one that is seen with some frequency in cattle, and that is lymphoma. For some reason, lymphoma is really attracted to the extradural fat. It almost always arises in the extradural fat. We call it spinal lymphoma, but it's not in the spinal cord. It's compressing the spinal cord. It's an extradural. So make sure that you use those terms, intradural and extradural, and this particular tumor is within the bounds of the meninges, so it's going to destroy the spinal cord. This is a intradural neoplasm. Not much of the spinal cord left. It's from a large breed dog, probably a young animal, and it probably arose in between the 10th thoracic vertebra and the 2nd lumbar vertebra. For many years after its initial diagnosis, it was called the thoracolumbar tumor of large dogs. But the thing is that this tumor, when you look at it on the microscope, closely resembles a nephroblastoma. You will see the formation of tubules, and in some of the tubules you will see a papillary proliferation of the neoplastic endothelium, which resembles a glomerulus. It may have some primitive mesenchyme, and it will probably stain positively for a combination of Wilms tumor antigen and maybe PAX8, which is seen in tubule formation. And this is actually, and some people will call it a spinal nephroblastoma. I like that name. It is an ectopic focus of tissue from the developing kidney that gets caught up in the area of the neural tube, and it's just it's going to do what it's going to do. It does it in a delayed fashion. The spinal cord is enclosed within the spinal column, and you just have this rest of immature tissue derived from the mesonephric duct, and over time it tries to make a kidney, and it grows and it destroys the thoracolumbar spinal cord. Ectopic, nephroblastoma, spinal nephroblastoma, or thoracolumbar tumor of young dogs. It all does the same. It's a fantastic entity. It's really tough to tell this grossly. They do have a granular type of appearance. Have you seen a couple of them? But once again, it's tough to do gross pathology without the rest of the animal, so we would know that it's a large breed dog or whatever. So I love doing gross pathology in a vacuum, but let's not get carried away with the quality of our assessments. Here's a great but rare entity. I think this was first published by Ramesh Covey about 10 years ago in a dog. It's been seen in dogs and cats. We have a spinal cord here, and this is a form of anaplastic oligodendroglioma. Some people call it oligodendrogliomatosis. And what happens is it starts within the spinal cord and it crawls up the meninges. And this is incredibly neovascular, lots of vascularity in that. So it tends to be very hemorrhagic, and it makes it prone to bleeding, and then you get additional problems associated with bleeds in and around the spinal cord. So anaplastic oligodendroglioma. Some people call this spinal cord oligodendrogliomatosis. It's an unusual one, but it's been published, so it's probably worth knowing as a differential diagnosis for spinal cord tumors, especially in cats. And now let's move out to some other tumors. Here is a tumor that we diagnose here with some regularity in the dog. This is one actually from a cow, and I like to call this the dancing spinal cord tumor, but it's actually rising from the spinal roots. This is a nerve sheath tumor. These go by a lot of names, often used to depend on how much a nervous tissue versus fibrous connective tissue is in it. And people used to call these neurofibromas. Most of them now are called peripheral nerve sheath tumors. They can be benign or malignant, but the characteristics between those two can be very confusing. And so we usually refer to them as peripheral nerve sheath tumors. In the dog, in cattle, they're not uncommonly seen in the area of the spinal roots of the brachial plexus, or the lumbosacral plexus are probably the most common. This one was from an ox. This one was from a dog. They've also been called schwannomas. We now call them peripheral nerve sheath tumors. And they're very common in the skin of the dog and in certain species. For example, we see them very commonly in the faces of cats and ferrets because of the tremendous numbers of very small nerves in there. So I don't know if there's in humans they use the old terminology of neurofibromas and neurolimomas and schwannomas, and I don't know if there is a consensus classification scheme in people, so we call them all peripheral nerve sheath tumors. They're all locally aggressive. They're probably all low-grade malignancies, and I don't know if I've seen one that I could really point at and say, this is benign. However, if you look at, they are one of the variants of the canine cutaneous spindle cell sarcomas or soft tissue sarcomas, and in those we tend to look at a number of features, including mitotic rate and evidence of necrosis for a clue as to how aggressive they will be in the future. Well, this brings us to the end of this particular lecture. I want to thank you for hanging in. I will mention a couple of books for those of you who are interested in neuropathology. one of the books that I like. It's not a big book, and it really boils down the information on a lot of these entities, is Veterinary Neuropathology, Essentials of Theory and Practice by Van de Velde, Higgins, and Overman. It's a great book, and it's very well illustrated. De La Hunta's Veterinary Neuroanatomy and Clinical Neurology has some excellent sections on the various pathologies and tumors of the nervous system and how they impact on neurologic function. I think that on a case-based basis that can be very useful. And then if you really want to be inspired by neuropathology, Innes and Saunders' Veterinary Neuropathology, written all the way back in the 1970s, before immuno was available, is a very encyclopedic book which shows how well they understood many of these entities so many years ago. With that, I'm going to close this lecture series down. Thanks so much for hanging in there. As always, I wish you a wonderful day, fantastic health, and I'll see you next time.